The management of women with red cell antibodies during pregnancy. Green Top Guideline number 65, May 2014. Introduction and Background Epidemiology. The presence of maternal red cell antibodies during pregnancy is a relatively common findings and requires close collaboration between the blood transfusion laboratory, obstetric, and neonatal care providers. The presence of red cell antibodies signifies alloimmunization that has occurred as a result of previous pregnancy, transfusion, or transplantation. Hemolytic disease of the fetus and newborn, or HDFN, is a condition in which transplacental passage of maternal immunoglobulin G, or IgG antibodies, results in immune hemolysis of fetal or neonatal red cells. Some antibodies, including anti-D, anti-Cal, and anti-C, confer significant fetal and neonatal risk such as anemia requiring intrauterine or neonatal transfusion, jaundice, or perinatal loss. Anti-D is the most commonly encountered antibody during pregnancy. Before routine antenatal anti-D prophylaxis, late immunization during a first pregnancy was responsible for 18 to 27% of cases. Pre-pregnancy counseling. Is pre-pregnancy counseling necessary for women known to have red cell antibodies prior to pregnancy? Women with red cell antibodies, particularly if there is a risk of fetal anemia or if compatible donor red cells for transfusion may be difficult to obtain, should attend for pre-pregnancy counseling with a clinician with knowledge and expertise of this condition. Assisted reproductive techniques, or ART. Do assisted reproductive techniques, or ART, increase the risk of red cell antibodies developing? There is no evidence that assisted reproductive techniques, or ART, increases the risk of red cell alloimmunization. However, if donor eggs are used for a mother with an alloantibody and the donor red cell antigen status is not known, fetal genotyping may be required. Red cell antibodies in pregnancy. In a population study, the prevalence of positive antibody screens was 1:80 with a 1:300 prevalence of clinically significant alloantibodies other than anti-D. Previous blood transfusion is an important cause for alloimmunization with antibodies other than anti-D implicated in hemolytic disease of the fetus and newborn. What red cell antibodies are clinically significant, maternal and fetal, during pregnancy? All women should have their blood group and antibody status determined at booking and at 28 weeks of gestation. Antibodies to many of the red cell antigens have the potential to be clinically significant and will have implications for the selection of blood for transfusion in the mother to avoid the risk of hemolytic transfusion reactions. For this reason, the blood group and the antibody status of the mother should be tested at booking and at 28 weeks of gestation. In addition to the risk of fetal anemia, the presence of maternal red cell antibodies can hinder the timely provision of blood and blood components because of difficulty in obtaining antigen-negative blood and/or cross-matching issues. The risk of fetal anemia is greatest with anti-D, anti-C, and anti-K antibodies. What are the implications for the fetus and neonate from red cell antibodies? Clinicians should be aware that severe fetal anemia can result in hydrops, which significantly worsens the perinatal outcome. Fetal anemia, hyperbilirubinemia, and neonatal jaundice can result from red cell antibodies that cause hemolysis or impaired erythropoiesis in utero. Untreated, severe fetal anemia can result in hydrops, preterm birth, or perinatal death. The overall perinatal survival in pregnancies complicated by red cell antibodies causing fetal anemia following treatment was reported to be 84%, with non-hydropic fetuses having better survival 94% than hydropic fetuses 74%. Anti-K causes anemia secondary to erythroid suppression and immune destruction of early erythroid progenitor cells, but hyperbilirubinemia is not a prominent feature. Severe fetal anemia can occur even at relatively low antibody titers. When and how should paternal and fetal genotyping be performed? Non-invasive fetal genotyping using maternal blood is now possible for D, C, E, and K antigens. These should be performed in the first instance for the relevant antigen when maternal red cell antibodies are present. For other antigens, invasive testing, such as chorionic villus sampling or CVS, or amniocentesis, may be considered if fetal anemia is a concern or if invasive testing is performed for another reason, for example, karyotyping. Where clinically significant maternal red cell antibodies are detected, the paternal phenotype can be ascertained by serology. However, with the rhesus-D or RHD antigen specifically in an antigen-positive father, while a likely phenotype can be deduced, genotyping is required to determine whether he is homozygous or heterozygous for the RHD gene. If the father is homozygous for the red cell antigen, then all pregnancies are potentially at risk. It is also reasonable to omit paternal testing and proceed directly to fetal genotyping to avoid issues of non-paternity. Genotyping can be undertaken from 16 weeks of gestation for all, except K, which can be undertaken from 20 weeks, due to the risk of a false negative result if performed earlier in pregnancy. However, in some cases, results are inconclusive as it is not possible to confirm that fetal DNA as well as maternal DNA is present in the sample. In these cases, consideration may need to be given to repeating the non-invasive test, performing an amniocentesis, or managing the pregnancy as one that is at risk. It is also reasonable not to perform fetal genotyping until the antibody reaches a level that would warrant fetal middle cerebral artery or MCA Doppler monitoring. Of note, in dizygotic twins, a maternal blood test for fetal genotyping will not differentiate between the twins, just that at least one has the corresponding gene. If fetal monitoring for anemia is indicated, each twin would need to be monitored separately. Non-invasive genotyping is not possible for some red cell antigens. In these cases, invasive testing, chorionic villus sampling or CVS, or amniocentesis may be considered. However, the risks of the procedure, miscarriage, worsening of alloimmunization, need to be balanced against the benefit that knowledge of the fetal genotype brings to the management of the pregnancy. It would normally only be indicated if there was a history of a significant problem with HDFN or hemolytic disease of the fetus and newborn, or MCA Doppler ultrasound suggested developing fetal anemia and intrauterine transfusion or IUT was being considered. Is karyotyping contraindicated in the presence of maternal red cell antibodies? Invasive testing is not contraindicated if alloimmunization has occurred. Anti-D prophylaxis should be given to cover invasive testing if the mother is RHD negative and is not sensitized. If the fetus is at risk of anemia, when should referral to a fetal medicine specialist take place? Referral to a fetal medicine specialist should occur when there are rising antibody levels or titers, a level or titer above a specific threshold, or ultrasound features suggestive of fetal anemia. Referral should take place if there is a history of unexplained severe neonatal jaundice, neonatal anemia requiring transfusion or exchange transfusion in order to exclude hemolytic disease of the fetus and newborn as the cause. For antibodies other than anti-D, anti-C, and anti-K, the following should prompt referral to a fetal medicine specialist: a history of previous significant HDFN or hemolytic disease of the fetus and newborn, or IUT or intrauterine transfusion, or a titer of 32 or above, especially if the titer is rising, as rising titers correlate with increasing risk and severity of anemia. What thresholds should be used for the various antibodies that could cause fetal anemia to trigger a referral for further investigation or monitoring? An anti-D level of greater than 4 international units per milliliter but less than 15 international units per milliliter correlates with a moderate risk of HDFN or hemolytic disease of the fetus and newborn, and an anti-D level of greater than 15 international units per milliliter can cause severe HDFN. Referral for a fetal medicine opinion should therefore be made once anti-D levels are greater than 4 international units per milliliter. An anti-C level of greater than 7.5 international units per milliliter but less than 20 international units per milliliter correlates with a moderate risk of HDFN, whereas an anti-C level of greater than 20 international units per milliliter correlates with a high risk of HDFN. Referral for a fetal medicine opinion should therefore be made once anti-C levels are greater than 7.5 international units per milliliter. For anti-K antibodies, referral should take place once detected, as severe fetal anemia can occur even with low titers. The presence of anti-E potentiates the severity of fetal anemia due to anti-C antibodies, so that referral at lower levels or titers is indicated unless the fetus has only one of these antigens. Once referral to a fetal medicine specialist has been made for assessment of pregnancy at moderate or high risk of hemolytic disease of the fetus and newborn, the value of subsequent quantitation of anti-D and anti-C levels is doubtful. Further testing is, however, required at 28 weeks for the development of additional red cell antibodies. Caution is required, however, if there is a history of a severely affected previous pregnancy, even if the antibody levels are low in the current pregnancy. For such cases, early referral to a fetal medicine specialist should be made so that an expert assessment of risk can be undertaken. For these women, ultrasound monitoring may be required even with low antibody levels. Anti-K titers appear to correlate poorly with the severity of disease with fetal anemia occurring at titers as low as 8. Once detected, how often should antibody levels be monitored during pregnancy? Anti-D and anti-C levels should be measured every 4 weeks up to 28 weeks of gestation, and then every 2 weeks until delivery. Although anti-K titers do not correlate well with either the development or severity of fetal anemia, titers should nevertheless be measured every 4 weeks up to 28 weeks of gestation, then every 2 weeks until delivery. For all other antibodies, retesting at 28 weeks is advised, with the exemption of women who have a previous history of pregnancies affected with hemolytic disease of the fetus and newborn, when early referral to a fetal medicine specialist is also recommended. For antibodies that could potentially cause problems with cross-matching or issues with the availability of appropriate blood, discussion with the blood transfusion service is required regarding the frequency of antenatal testing. This may depend on the type of antibody as well as the likelihood of requiring blood at short notice. How should pregnancies at risk of fetal anemia be monitored? The cause of the alloimmunization, relevant past history, and pregnancy outcomes should be ascertained in order to generate an assessment of risk of HDFN or hemolytic disease of the fetus and newborn. If the fetus carries the corresponding antigen for a maternal antibody, which is capable of causing fetal anemia, and if the antibody levels or titers rise beyond the levels, then the pregnancy should be monitored weekly by ultrasound, specifically assessing the fetal middle cerebral artery peak systolic velocities or MCA-PSV. Referral to a fetal medicine specialist for consideration of invasive treatment should take place if the MCA-PSV rises above the 1.5 multiples of the median or MOM threshold, or if there are other signs of fetal anemia. Fetal monitoring is required once anti-K is detected. The cause of the alloimmunization should be ascertained. For example, inadequate or omitted anti-D prophylaxis or a previous blood transfusion. Details of previously affected pregnancies, particularly IUTs, and the gestation at which they were commenced, neonatal anemia, gestation at delivery, and the need for exchange transfusions or phototherapy should also be obtained. This information enables a risk assessment of the pregnancy to be made. Ultrasound monitoring should commence once there is a moderate or severe risk of fetal anemia. If the fetus is antigen positive, it will be at risk of anemia, and the pregnancy needs to be serially monitored. Pregnancies at risk should be monitored on a weekly basis, looking specifically at the MCA-PSV or middle cerebral artery peak systolic velocities. Other signs that might suggest fetal anemia include polyhydramnios, skin edema, and cardiomegaly. Although the risks of fetal anemia are well known for anti-D, anti-C, and anti-K antibodies, and weekly monitoring is advisable, the risks for other less common antibodies is difficult to precisely quantify. A reasonable approach would be ultrasound monitoring every 1 to 2 weeks using the MCA-PSV. Middle cerebral artery peak systolic velocity monitoring is predictive of moderate or severe fetal anemia with 100% sensitivity and a false positive rate at 12%. If monitoring of the MCA indicates anemia, MCA-PSV greater than 1.5 multiple of the median, fetal blood sampling or FPS, and possibly IUT or intrauterine transfusion are indicated. Monitoring with MCA-PSV should be used with caution after 36 weeks as its sensitivity for the detection of fetal anemia decreases. Further management should be discussed with a fetal medicine specialist if MCA-PSV levels are normal despite high or increasing antibody levels beyond 36 weeks of gestation. The risk of fetal loss following an FBS is 1 to 3%, but is higher if the fetus is hydropic. The procedure is carried out under continuous ultrasound guidance with facilities for immediate analysis of the fetal blood hemoglobin and hematocrit. The risks and benefits of IUT or intrauterine transfusion should always be discussed with the woman, who should be made aware of the consequences of untreated severe fetal anemia, for example, hydrops, preterm birth, perinatal death, severe neonatal jaundice, and kernicterus, as well as the risk of neonatal exchange transfusion. If fetal transfusion is required, what type of donor blood should be used? Red cell preparations for IUT or intrauterine transfusion should be Group O, low titer hemolysin, or ABO identical with the fetus if known, and negative for the antigen or antigens corresponding to maternal red cell antibodies. Blood should be IAT or indirect antiglobulin test cross-match compatible with maternal plasma and negative for the relevant antigen or antigens determined by maternal antibody status. K-negative blood is recommended to reduce additional maternal alloimmunization risk. It should also be less than 5 days old and in citrate phosphate dextrose or CPD anticoagulant, cytomegalovirus or CMV seronegative, irradiated and transfused within 24 hours of irradiation. Blood packs should have a hematocrit, packed cell volume or PCV, of 0.70 to 0.85. Blood for IUT or intrauterine transfusion should never be transfused straight from 4 degrees Celsius storage. Intrauterine transfusions or IUTs should be performed only in fetal medicine units that have the requisite invasive skills and appropriate perinatal hematology expertise. What are the implications for the mother from red cell antibodies? For antibodies other than anti-D, anti-C, anti-C, anti-E, or anti-K, maternity staff should liaise with their local transfusion laboratory to assess and plan for any possible transfusion requirements, as obtaining the relevant blood may take longer. How often should pregnant women with red cell antibodies who are at high risk of requiring a transfusion, placenta previa, sickle cell disease, and etc., be tested? Pregnant women with red cell antibodies who are assessed as being at high risk of requiring a blood transfusion should have a cross-match sample taken at least every week. Current British Committee for Standards and Hematology guidelines require a sample no more than 72 hours old for providing compatible blood in pregnancy, but do allow a deviation to the 3-day rule for individual cases, such as high-risk women with placenta previa without red cell antibodies, where weekly samples can be taken, as long as a risk assessment is made and recorded in each individual case. In high-risk women with red cell antibodies, where a sample every 72 hours is not feasible, a sample should be taken once a week, and if transfusion is required, a new sample should be taken immediately, to exclude new antibody development. If maternal transfusion is required, what type of donor blood or blood components should be used? Red cell components of the same ABO group and RHD type and that are K negative and CMV negative should be selected. If group ABO identical blood is not available for group A, B, or AB patients, group O blood should be used. Pregnant women and women of childbearing age who are RHD negative should receive RHD negative blood. The transfused blood should also be K negative. An IAT cross-match must be used if the woman's plasma contains or has previously contained clinically significant red cell alloantibodies. For planned antenatal transfusions, CMV or cytomegalovirus negative blood should be transfused. Screening for CMV or cytomegalovirus should not delay transfusion in an emergency situation. Should RHD negative women who have anti-D or non-anti-D antibodies receive routine antenatal or postnatal prophylaxis? Anti-D immunoglobulin should be given to RHD negative women with non-anti-D antibodies for routine antenatal prophylaxis for potential antenatal sensitizing events and postnatal prophylaxis. If immune anti-D is detected, prophylaxis is no longer necessary. Discussion and liaison with the transfusion laboratory are essential in determining whether anti-D antibodies are immune or passive in women who have previously received anti-D prophylaxis. Requirements for blood. What are the logistics of obtaining blood or blood components for the woman, fetus, or neonate? Blood or blood components for the woman. Close collaboration between the maternity, neonatology, and hematology staff is essential. When blood is required for women with multiple antibodies or antibodies against high prevalence antigens, planning is required as rare blood donors may need to be called up to donate, or frozen blood may need to be obtained from the National Frozen Blood Bank in Liverpool. Local blood transport time and time for cross-match should be taken into account when the decision for transfusion is made. Blood for intrauterine transfusion or IUT. Clinicians should be aware that blood for IUT has the same requirements as blood for neonatal exchange, except that plasma is removed by the blood center to increase the hematocrit to 0.70 to 0.85, and it is always irradiated. Blood for neonatal exchange. Blood should be ABO compatible with the neonate and mother to avoid ABO HDFN from the women's anti-A or B antibodies present, RHD negative or RHD identical with the neonate, K negative, negative for the corresponding antigen to which the woman has an antibody and cross-match compatible with the woman's blood sample. Blood should be less than 5 days old to ensure low supernatant potassium levels, CMV or cytomegalovirus negative, and irradiated unless the risk to the baby of delaying exchange transfusion while obtaining irradiated blood outweighs this. It should be plasma reduced rather than in saline adenine glucose mannitol or SAGM additive solution with a hematocrit of 0.50 to 0.60. Once irradiated, exchanged blood has a shelf life of 24 hours. Blood should be cytomegalovirus negative to minimize the risk of cytomegalovirus infection in the neonate, and irradiated to prevent transfusion-associated graft versus host disease due to the large volume of blood transfused to a neonate. Plasma-reduced blood is preferable as blood suspended in the saline adenine glucose mannitol or SAGM contains glucose, which can result in rebound hypoglycemia, and mannitol with potential diuretic and intracerebral pressure effects. The recommended hematocrit allows for sufficient correction of anemia after exchange, but without an unacceptably high hematocrit with its associated risk to the neonate. Blood for neonatal small volume or top-up transfusion. Blood should be ABO compatible with the neonate and mother to avoid ABO HDFN from the woman's anti-A or anti-B antibodies present, RHD negative or RHD identical with neonate, K negative, and negative for the corresponding antigen to which the woman has an antibody and cross-match compatible with the woman's blood sample. Blood should be CMV or cytomegalovirus negative, but does not need to be irradiated unless the neonate has had a previous intrauterine transfusion, and blood can be stored in SAGM rather than plasma-reduced and be up to 35 days old, as a top-up transfusion is a much smaller volume than an exchange transfusion. Clinicians considering transfusion in a neonate must check if the baby has had an intrauterine transfusion or IUT, as if so, blood must be irradiated to prevent transfusion-associated graft versus host disease. While blood for IUT or intrauterine transfusion should be irradiated because of the physiological immune incompetence of the fetus, allowing transfusion-induced tolerance or immunosuppression for top-up, small volume neonatal transfusions in the absence of any preceding IUT, irradiation is not required. If ABO negative, RHD negative, and K negative compatible blood that is not matched for other antibodies is used for resuscitation in the event of life-threatening hemorrhage, consider giving intravenous methylprednisolone 1 gram and monitor the woman closely. If a severe transfusion reaction develops, full resuscitative measures, including the use of adrenaline, may be required. The presence of maternal red cell antibodies has no implications for other blood components such as platelets, fresh frozen plasma, cryoprecipitate, or fractionated products. What blood or blood components can be administered in the emergency situation to a woman known to have red cell antibodies? The decision to use ABO negative, RHD negative, and K negative compatible blood that is not matched for other antibodies or O negative, where the woman's ABO and RHD groups are unknown, should be made on the balance of risk, severe hemorrhage versus a hemolytic transfusion reaction. Transfusion should not be delayed in the event of life-threatening hemorrhage. Close liaison with the transfusion laboratory is essential. Birth. What is the optimum mode, place, and timing of birth? Timing of delivery for women with red cell antibodies that can cause fetal anemia will depend on the antibody levels or titers, rate of rise, as well as if any fetal therapy has been required. The mode, timing, and place of delivery are otherwise dependent on standard obstetric grounds. If a woman is at risk of requiring significant amounts of transfused blood, either antenatally, intrapartum, or postnatally, consideration should be given to transferring her care to a center capable of processing cross-matched samples and providing appropriate compatible blood rapidly. As these are high-risk pregnancies, continuous electronic fetal heart monitoring is advised during labor. In general, for red cell antibodies that could cause fetal anemia, but which have been stable throughout pregnancy, delivery should take place between 37 and 38 weeks of gestation. If an intrauterine transfusion or IUT has not been required, but antibody levels are rising, then consideration for earlier delivery may be necessary. If an intrauterine transfusion or IUT has been required, delivery will need to be timed to ensure that the fetus is not significantly anemic at birth. This will depend on the gestation that the last IUT was performed, as well as the estimated rate of drop of fetal hemoglobin or hematocrit. Decisions about the timing of delivery are most appropriately made by the fetal medicine team managing these pregnancies. Prior IUT is not in itself an indication for elective cesarean section. The neonatal team should be advised of the timing of delivery in the event that further neonatal care is required. Cord blood investigations. What cord blood investigations should be performed? If a woman has clinically significant antibodies, then cord samples should be taken for a direct antiglobulin test or DIT, hemoglobin, and bilirubin levels. A positive DAT or direct antiglobulin test indicates that the infant's red cells are coated with antibody, but in itself cannot predict severity of hemolysis. Notably, the DAT may be negative in ABO-HDFN or ABO hemolytic disease of the fetus and newborn. It is therefore essential to also determine hemoglobin and bilirubin levels to ascertain the degree of anemia and hemolysis at birth, and this helps guide management as below. Management. How should the neonate be managed? This depends on the risk of hemolysis or anemia conferred by the relevant red cell antibody. The neonate should have regular clinical assessment of its neurobehavioral state and be observed for the development of jaundice and/or anemia. Regular assessment of bilirubin and hemoglobin levels should be made and early discharge is not advisable. The mother should be encouraged to feed the baby regularly to guard against dehydration, since dehydration can increase the severity of jaundice. Clinicians should be aware that if bilirubin levels rise rapidly or above the interventional threshold, phototherapy and/or exchange transfusion may be required. Pregnancy is complicated by red cell alloimmunization with a minimal or no risk of fetal or neonatal anemia, require no specific treatment. Exchange transfusion may be used to manage severe anemia at birth and to treat severe hypobilirubinemia. Such a transfusion is undertaken with the aims of removing both the antibody-coated red cells and the excess bilirubin. Future risk. What is the risk of recurrence in a future pregnancy? A woman with a history of a pregnancy or infant affected by HDFN should be referred for early assessment to a fetal medicine specialist in all further pregnancies. The risk of recurrence of hemolytic disease of the fetus and newborn, or HDFN, depends on the type of antibody, the paternal genotype, as well as the severity and gestational onset of the fetal anemia. Long-term consequences of red cell antibodies to women and their offspring. What are the long-term health consequences for the women? Women can be advised that there are no long-term adverse health consequences associated with the presence of red cell antibodies. What are the long-term health concerns for the children of women with red cell antibodies during pregnancy? Clinicians should be aware that some infants may experience anemia persisting for a few weeks following birth. Clinicians should be aware that some infants may develop late anemia, which is usually due to hyporegenerative anemia. Anemia persisting for a few weeks after birth is usually the result of passively acquired maternal antibodies causing continued hemolysis. Late anemia may develop due to a transient suppression of neonatal erythropoiesis, itself due to transfusion. Babies who have required several intrauterine transfusions or IUTs are at particular risk. Affected infants have suppression of erythropoiesis with low numbers of reticulocytes despite a low packed cell volume and normal erythropoietin values. Top-up transfusions are required only if the infant is symptomatic. There is some evidence that the need and frequency of top-up transfusions may be decreased if recombinant erythropoietin is used. Sensory neural hearing loss is more common in infants affected by hemolytic disease of the newborn because of the toxic effect of prolonged exposure of bilirubin on the developing 8th cranial nerve.